with those broad comments, I will carry on. So we do a lot of aortic procedures, and many years ago when I was at Crawford, I looked at our patients with deep hypothermia and circulatory arrest, which is a key to a successful procedure. And when we looked at the risk of stroke, the safe period in green was out to about 40 minutes with just cooling and deep hypothermia. And then after 65 minutes, it looks like the risk of stroke declines. As you know, that's not the case. It's a statistical quirk, because what happens is at 65 minutes, your risk of mortality goes up considerably, and so you're missing the strokes. The patients die before they can be assessed. Now, one of the things that happened at Baylor many, many years ago, in 1963 or 4, was the first LVAD procedure. Now, most people think of that as Dr. DeBakey. It was actually Dr. Crawford who did the first LVAD. And he used the subclavian artery for arterial inflow. And here's a picture of the patient, the first patient. And that gave me the idea that we should use the subclavian artery for arterial inflow. And so that's what we started doing with balloon catheters in the greater vessels. And we then looked at some 1,300 patients at the Cleveland Clinic who had various types of operation, including descendings with circulatory arrest and mitral valves with arrest, and then looked at the risk of death and stroke. And what we found was that the stroke rate was considerably lower, significantly so if you sewed a side graft onto the subclavian or axillary and perfused the patients that way. So the risk of stroke was 40% less. And that's, I think, a starting point on how to do these type of procedures. So more recently, we did a prospective randomized trial on brain protection. This was for total arch replacements, 121 patients, cool the patients to below 20 degrees. We used double coolers. Forget about the gradients. The usual teaching is you can't have more than a 10-degree gradient. Forget about it. Just warm the patient up, cool the patient down as quickly as you can, or the reverse. And then putting the patient's head in ice, I think, is important. We use carbon dioxide flooding of the field at 10 liters. I think the most important reason why patients have strokes is because you don't get the air out of the arch. There's business about all types of perfusion techniques and, this, that, and antegrade, retrograde brain perfusion, etc. Just make sure you don't have any air in the arch. And then the subclavian side graft. In the randomized trial, we used antegrade brain perfusion at 40 to 60 millimeters of mercury every 15 minutes. And that's based on the very good data from deep hypothermia and circulatory arrest for endarterectomy or pulmonary arteries, which obviously you don't open the brain, or expose the brain to air typically. And retrograde at 20 to 30 milligrams. We had a neurological examination before and after surgery in these patients. And then we did pre-op and post-op MRI and neurocognitive testing. So you've seen some of the data with the various frozen elephant trunks, and the mortality rates run anywhere from 5 to 15%. Now this is a slightly different situation because these were elective patients because we had to get permission and they got the neurocognitive testing. But here's the outcome. So 39% were redos, 61% had elephant trunks. Mortality rate 0.8%, clinical stroke 0.8%. So that's clinical examination. Now on imaging, we did find that 15% on MRI had evidence of having had a stroke, and neurocognitive decline was 18%. Now, the overall is 24%. What's interesting, and intuitively we should have thought about this, you can have a stroke in the cerebellum or posterior brain, but no neurocognitive deficit because basically won't be too affected by that. And similarly, you can have neurocognitive deficits because they might be so subtle that you don't see them on the imaging. So basically 1/4 of patients on more careful testing had some evidence. No difference between antegrade and retrograde. And as I mentioned, some areas were silent. So this is what can be achieved if you're meticulous about your technique for brain protection during arch surgery. And then we also looked at the change in the scoring of defects in the parts of the brain comparing pre-op versus post-op, and basically no difference there. So As Jeffrey said, and Jeffrey, that was a very nice presentation, I enjoyed it. The elephant trunk procedure to me is the key to doing arch surgery, and it's up-to-date sort of versions for the frozen elephant trunk. And this is hiking in Zimbabwe and coming across the elephant, which is quite an experience. Now, in the patients with acute dissection, for most patients, we will just transect the aorta at the subclavian into the arch and at the ST junction, sew a tube graft in, get hemostasis with interrupted horizontal mattress sutures outside for the arch, posterior wall. I put them inside the aorta. You don't need glue, you don't need strips, just simple, keep it simple, and you'll have great results. Now, in the patients who've got an extensive tear or big arch or a leak in the arch, then certainly the various frozen elephant trunks are an option, and we do them, and the results are pretty good. So the basic elephant trunk procedure I still think is very important, which is sewing the graft into position with an invert in the descending aorta. We used to use a side graft on the side. I will still use that sometimes in the patients with acute dissection where you cannot flow adequately through the subclavian, which happens, or use the femoral artery with a wide-off graft. A critical thing is to put plagets at your distal anastomosis so that you've got no leaking there and you don't have later, when you come to do a second stage, a perigraft leak. And then sew in the posterior wall and then the anterior wall. Now, we classified our elephant trunk procedures a year or two ago, and at that stage we had about 520 odd patients. Now we're up to 720 odd, based on whether you use a stent graft at the same time. Now, one of the things that Jeffrey mentioned is the curve in the aortic arch. This is the way I like to do it, which is it happens to be Vascutech, and I don't have any financial interest in it, as I mentioned earlier. They made us a triple graft for hooking up the subclavian, the carotid, and the nominates, and then to the back of that, I sew my elephant trunk. That way you get around the issue of the curve in the aortic arch. And here's just some of the options with so-called debranching with separate vessels and then stenting into that. And you have a couple of examples of these type of procedures, just putting in the various types. Now, a couple of comments about the more chronic patients. I put a wedge in the descending aorta so that there's perfusion of both the true and the false lumens. I preferentially stuff the elephant trunk into the true lumen, but you have to be careful about not obliterating any intercostals coming off the false lumen with the risk of paralysis. And here's another version with sewing the elephant trunk between the carotid and the subclavian. We've done about 40 patients this way. The stroke rate may be slightly higher, but it seems to be a reasonable approach, and then replacing the rest of the aorta. So these are the sort of patients you get with extensive aneurysms and dissection. Fortunately, perhaps not as common now as we used to. And here's an elephant trunk with the old composite valve graft as a Cabral. We don't use that any longer. What I do is I put a tube graft to the left main and do the right as a button. That's a much safer way of doing those patients. And there's a second stage. One of the things to remember, and this is just an example and was brought up, the connective tissue disorder patients. This is a Lamol stent. If any of you have ever seen that, probably not. That was a stent that you tied into position in the ascending aorta. And this is a patient who had a procedure done and then aneurysm formation of the arch and the coronary ostia. So in the patients with connective tissue disorders, we tend to put separate tube grafts to the carotids and the nominate artery as needed. So one of the options to bail out sometimes is the total aorta or total thoracic aorta replacement of one operation using a mediastinal incision and a thoracoabdominal incision. I used to do that, and I backed off because our mortality rate was 17%, but in some patients, this is one option to get you out of trouble when you can't do the elephant trunk procedure. And this is a patient who lived many years afterwards. In fact, was the first patient with 60 minutes of circulatory arrest intermittently and replacement of his entire aorta. So here's another patient, a Norwegian patient, where elephant trunk procedure. And if you look at the distal end of the elephant trunk, you see we tie a pacing wire and put some metal clips on the end, and that facilitates stenting at a later operation. Here's another patient, slightly different. It's worthwhile telling the story, and this is a parabat. He was jumping with the Air Force, and he jumped, and a flock of geese flew into him and collapsed his parachute, fell to the ground. He was quadriplegic, had a brain bleed, and then he had a stent put into the aortic arch with that bird beak deformity. And so we couldn't put him on pump, we couldn't heparinize him, and we put a side graft from the ascending aorta to the greater vessels and then stented the rest of his aorta. Fortunately, he recovered from his quadriplegia. Hopefully he doesn't go jumping around in parachutes with geese around him. So there's the operation with that in place and the stents in place too. And there's just another picture with the stent within the stent. So the other options are putting in stents through the side grafts and the ascending aorta. But I think one point about the elephant trunk procedure is that you have an anchor point. So you divide, in a sense, your aneurysm between the proximal and descending aorta. And we've had a number of these type of patients now come back with ruptured arches or thoracoabdominis aorta, and then that's an impossible operation. I mean, you can do it, but it's really high risk then to try and replace the ascending aorta, the arch, and the descending aorta all at one time with deep hypothermia, circulatory arrest from the left chest. So the elephant trunk does segregate the two areas, making it easier to manage problems. And here's just examples. The critical part is getting that angle right for perfusion of the greater vessels. Here's another different patient with similar problem. Now, we also have seen an increasing number of patients with ascending dissections from stenting of the descending aorta. This is one of the patients, Roy Greenberg put a stent in their arch with a separate bare stent in the carotid and dissected the ascending aorta. So that's a group of patients we're seeing more frequently. Here's another patient with a leak from a fenestrated graft in the aortic arch, and the bailout here, I put in the elephant trunk in the descending aorta so we could then do the second stage for that way. There's a closer up of that. And here's a elephant trunk in place within a stent in the descending aorta, similar type of procedure. This is a patient, as I mentioned, who had acute dissection, gut ischemia, small true lumen, collapsed the SMA. We stented his SMA and his true lumen, and then came back and did a reimplantation operation and then replaced his arch. So here's another picture of the debranching, and I'll come back to this patient a bit later. And here's now the second stage of that particular patient from Norway with the descending aorta and stenting and eventually replacement down to the iliacs. Now, stenting the elephant trunks, this is a fairly straightforward procedure in the patients who are just descending aneurysms. This is a stent in the descending aorta. This happens to be a bit of a mafia godfather. Obviously, some risk in dealing with those kind of patients. Now, here is a patient who was stented in an elephant trunk done elsewhere. And here, this is one of the dangers if you put a stent in an elephant trunk and you don't straighten out that elephant trunk. And that's one of the reasons why we put those clips and pacing wires on the elephant trunk so you can pull it and straighten it out. And there, that's progression over time of that elephant trunk. So there you can see the clips and the wires on the end of the elephant trunk. There's just another image of that, and that allows you to straighten out the elephant trunk for the second operation. And there you have that done there. And there you can actually see the pacing wire with the stent inside that area there. So we also went through a period with the elephant trunks where we did debranching from the iliacs to the viscerals and then stented the rest of the aorta we had a high mortality rate and paraplegia rate in these patients, and so we abandoned that, and that's why we went more to the branch grafts in those patients. And this operation I did together with Roy Greenberg, where we stented down into the iliacs. And there's the more recent way we do it with stents into the viscerals. So here's a different scenario. This is a patient in his 60s, heavy smoker, oxygen dependent, with a dissection leak in the descending aorta, and also severe aortic valve regurgitation. And here what we did was we put in a valve, did an arch elephant trunk, and wrapped the descending aorta just above the celiac, and then stented into the wrap. And here's the images just of the sequence, and there's the stent going into the wrap, and there you have the x-ray with the complete stenting, and there's the CT scan showing that going into the descending. Now here's the patient I showed earlier with a debranching. He was a young 22-year-old, some type of connective tissue disorder. When I did his thoraco, I did an elephant trunk just below the viscera, debranched his visceral arteries with the expectation that he would probably become aneurysmal later in the abdominal aorta. And sure enough, within 2 years, he had abdominal aneurysm, and it was fairly easy then to stent into the iliacs since we had a good landing site. So going into some of the results, this is our series of endovascular procedures, end of 2013, various thoracoabdominal extents and descendings. These are the extents of coverage. In 58% we use CSF drainage. All our thoracos, we use CSF drainage with intrathecal papaverine, which we showed reduced our risk of paraplegia considerably. And so that's something I recommend for that. I haven't been able to convince everybody to use papaverine for the thoracoabdominal stenting, but I think logically that would be a way to do it. Here are the results in that series: 7.9% mortality rate. And remember, this included the emergency procedures. The predictors of early death are shown there, and emergencies are obviously a very big part of the early deaths, late deaths, dialysis, and dissection being factors, and the paraplegia risk factors are shown there. We've done a number of patients, this video unfortunately doesn't play, but where we've done combined aortic valve, TAVRs, or TAVI as you call it here, and then put stents in the aortic arch at the same time as doing the transapical procedures. And for our ascending stent grafts, that's a way we do quite a lot of those patients. Now, over time, hopefully all your elephant trunks go to get a second stage procedure, but you have some patients who die before that, and that's always been the challenge of the elephant trunk procedure, one of the advantages of the endovascular approach. But all the patients who had their second stage, the long-term survival is pretty reasonable, and freedom from reoperation is pretty good too. And completing it is dependent on the size of the aorta. So one of the studies we did a few years ago is looking at second stage elephant trunk procedures and whether we did them open or endovascular. Not much difference in the mortality rate, open versus stenting. The big difference was 25 endoleaks with the stent patients, and that's the price for the endovascular approach. And if you look at survival, maybe a slightly better trend over time in the patients in blue here who had an open procedure for the second stage. So thank you very much for your attention, and